I recently reported on the XBOS study, which is a great way to learn about the presence of extremity pain or symptoms that are coming from the spine, or at least resolved with moving the spine. And this study I want to talk about today is piggybacking on the research from that study. This study is called Exploring Indicators of Extremity Pain of Spinal Source as Identified by Mechanical Diagnosis and Therapy, MDT, a secondary analysis of a prospective cohort study. So the secondary analysis of the original XBOS study, and I wrote in here the word isolated. It's not part of the title, but I just want to highlight these patients are not coming to clinicians and saying, my knee is on fire and my back is almost as bad, or my shoulder is bothering me and my neck is also really bothering me. They're reporting isolated extremity symptoms, usually pain, but not always. This study was written by Rastogi et al. I'm not sure if I'm saying that correctly, published online and published in JMMT in 2022. So recently published. I believe it's free online. So please take the time to take a look at this. But this study is asking the question, what in the specific verbal history and what in part 2 of the orthopedic evaluation when you take baselines, for example, range of motion, strength, nerve tension, functional baselines, what parts or what can we hear or see in those two parts of the exam that make us start to think that someone's ankle pain or someone's wrist pain or elbow pain is indeed coming from the spine, or at least we could say more vaguely, could be resolved by moving the spine in a specific direction. And that's a really great question. And I use the word specific verbal history. I try to add that word specific on there because what we ask patients is really important. And I've gotten better at that over the years. A verbal history where we just say, okay, we got 8 minutes, so tell me what's going on. The patient will give you their version of what's going on, but the clinicians know what other data points are important. For example, have you lost motion? Patients might not necessarily report stiffness. They're going to focus maybe on their pain. So we need to ask those questions. Of course, some of them are validated or verified when we start to move people in the physical exam in part 2. But there's a lot of things that I can glean from the specific verbal history that are very, very potent. If I had to choose between can I just do a physical exam or just do a verbal exam, I would choose the physical. But the verbal exam, when you do it right, is really funneling down the possible diagnoses and dictating what I test for in part 2, and then where I start with my repeated movement testing. So the specific verbal history is asking specific questions. And they're asking, what do we hear in the verbal history? What do we see in the baselines that make us start to think spinal source for an extremity complaint? And they found 5 things when they parsed out the data. And they said that the optimal number for predicting classification of spine versus extremity was 2. And I'm not quite sure why it's not more than that, but that's what they reported. So let's look at the 5 kind of criteria that they found that helped predict if the person's extremity symptom was coming from the spine or from the extremity. So paresthesia, which is just an altered sensation in that nerve, typically reported as tingling sensation. So if that is present, higher likelihood that the symptoms are coming from the spine. Now, this makes sense because paresthesia is a change in the nerve. And nerves typically, not always, but typically get compromised or irritated where they exit the small foramina in the spine, on the left side or the right side, or both, or centrally in the posterior compartment of the joint. Now, you can have nerves get irritated in the periphery. You can have entrapments, and I've mentioned before that carpal tunnel and Morton's neuroma are 2 of the top compressive neuropathies that we see in orthopedic medicine. But I don't find them as much as most people find them. And I find more spinal irritation for nerves than peripheral entrapment. And of course, if you have a blunt trauma to your arm, it's going to affect the nerves, especially the superficial nerves that they hit. But when I hear someone start to remark, yeah, my knee hurts and it's tingly, I'm starting to think this could be more likely from the spine versus the knee joint itself. Number 2 is change with sitting, change with neck or trunk flexion, change in symptoms with turning the neck, and changes when still. So we're listening for things that they're moving their spine and their extremity joints relatively inert. It's not being really taxed, and they're complaining of extremity symptoms. So we're starting to think, could this be spine, especially if they're reporting that, when I'm still, my ankle really hurts. Number 3 is a change with postural change. And they note that this was the most salient characteristic that helped predict if the symptom was coming from the spine. I believe they found an almost 4 times increased risk of it being from the spine versus not. When the patient reports, when we change the posture, the extremity symptom is affected. So historically, what that means, or most commonly what that means, is if the patient is in a kyphotic or slumped position in the chair in my office, I will have them go upright, possibly add a lumbar roll to maintain that lordosis, and ask if it changes the person's symptoms. In converse, we can have them flex and see if that increases or decreases their symptoms. I don't test postural change with every single patient. It's for the right patient. And I don't talk about it as much when I talk about the core parts of my orthopedic evaluation. And that's because I think there's a lot of acrimony and a lot of personal opinions about posture, and I just don't want to go into that. But I find posture to be extremely salient when it comes to orthopedic complaints. It's like asking why. Of course it would matter what you do to your musculoskeletal system all day in terms of creating symptoms. So I'm not changing everyone's posture, but if I think it's relevant to healing, or if I think it's relative or related to maintenance, we are absolutely addressing posture for that particular patient. So commonly we'll see that if we have people get upright, if they present and they're kind of slumped or slouched, we commonly see that that helps patients, and that would speak to maybe getting more spine extension into the patient's life could be fruitful. But it's just part of the puzzle. It's not the end all be all, but they found it was the most important of these 5. So number 4 that helps predict if the symptoms are coming from the spine is loss of spine range of motion. And that kind of makes intuitive sense. That's one of those questions I can't really ask that well. And so I base more of the spine range of motion more on part 2 of the physical exam, because most patients don't know how much spine extension they have in the lumbar spine, or side glide left or right. They may know how much flexion they have in terms of toe touching, and they may have noticed that they've lost it, but they're usually not regularly checking unless they're an athlete or someone who goes to yoga all the time, etc. Similarly, people don't tend to notice if they're missing neck extension because they never go into neck extension, but they might notice that it's harder to turn in the car, for example. So we can glean this from the specific verbal history. We can also glean this, obviously, from taking the orthopedic baselines of range of motion in part 2. And number 5 is if there's no loss of extremity range of motion. And I would say that that one, to me, is very powerful. If your knee hurts, but your knee moves well, I'm getting suspicious. Same with every other joint. Now, going back to posture, and I mentioned this before, when I have a patient who has an extremity joint complaint, I'm expecting to hear that they have problems when they put weight through that joint. So when the person comes in, and I can remember clearly this high school athlete that I saw several years ago who came in with significant knee pain that prevented him from playing his sport, which I think was basketball. And as he was sitting there, his knee was hurting. And I did postural change assessment with him. I sat him upright because as a high schooler, he sat kind of slouched like most do. I sat him upright. I put a lumbar roll behind him. We gave it a minute, and he said his knee pain went away. And he was luckily kind of astute enough to recognize that change. And the lumbar roll became a very important part of his rehabilitation, which didn't take very long. It was geared at lumbar extension for his knee pain, which is something that is not uncommon for me to see. And I believe he'd been told by another doctor that he had something wrong with his knee. But for him, it was just a simple mechanical problem in his back. But I don't see very often that they're coming in with knee pain and a lumbar roll abolishes that pain. But if it does, that's very, very powerful. Like I said, it's the most powerful indicator that they found in this study. So a specific verbal history and taking the baselines before we even get to the repeated movement testing can help clinicians start to question the diagnosis. And as I've mentioned before, the algorithm I'm thinking in my head is location, diagnosis, direction, force. So the first thing I'm trying to think about is where is the location of the root cause? And if your clinician is not even, in her mind thinking, could this be spine? You're off to a bad start, because we're finding that a large percentage of patients with isolated extremity pain do have a spinal source and do resolve their issue relatively quickly with movements of the spine in a specific direction, whether that's lumbar side glide to the left or thoracic rotation to the right or neck retraction extension. And when we find those, obviously the treatment is repeatedly moving into that one direction many times throughout the day. But location is first, then the diagnosis. Is it a joint derangement? Is it a tendinopathy? Is it a structural lesion, etc.? If it's a tendinopathy or a joint derangement, I'm curious, what direction do we need to move this patient into? What load? And then how much force do we need to apply? Please check out this study online. If you have questions, I'll try to answer them. But we need to start getting a systematic approach to understanding how to diagnose, starting with location. And this study, I think, is helping clinicians get a better idea of how to do that.